Hello, and thank you for joining us today for what I hope will be an interesting and informative discussion around the latest data in rheumatology. We're very fortunate today to have one of the sharpest thinkers in rheumatology, one of the key opinion leaders in psoriatic arthritis, and someone who always thinks out of the box, and we enjoy always chatting with Dennis. My name's Professor Peter Nash from Griffith University in beautiful downtown Brisbane. And today we have Professor Denis McGonagle, who's Professor of Investigative Rheumatology at the Academic Unit for Musculoskeletal Diseases and Leeds Teaching Hospital in the UK. It's a pleasure to have you with us today, Dennis. Thank you so much.
Hello, Peter.
And we'll be talking about an op-ed you wrote in British Journal of Rheumatology, also called Rheumatology, in August of this year, August of last year. And it's an important paper because it's one of the hottest topics in psoriatic arthritis. Can we prevent PSA by doing something about it at PSO? And to define this preclinical phase of psoriatic arthritis, if you like. So, Dennis, just tell the audience a little bit about yourself and where you work and what you do and what your interests are, just for a few introductory comments.
Yeah, hello, Peter. Nice to speak to you. Bright and early in the morning there in Brisbane and late at the night here in the UK. So I'm an academic rheumatologist in Leeds, where Werner Wright in the 1950s published the modern description of psoriatic arthritis in Annals, and then he subsequently, with Moll, described the spondyloarthropathy concept. So I happen to be one of the successors in Leeds of this great tradition, and where I study the earliest manifestations of psoriatic arthritis, which pathologically we believe is strongly linked to enthesitis as a triggering event in animals and humans. And that pathophysiological interest has led me naturally to, can we prevent psoriatic arthritis? And unlike rheumatoid prevention, where our eye is trained in on synovitis, in psoriatic arthritis prevention, our eye may be more naturally trained in on enthesitis, or the link between psoriasis and insertional point inflammation.
So let's have a look at this paper. You try to define early identification. Is there well-defined risk factors for who with psoriasis is going to develop psoriatic arthritis?
Yes, of course. The first thing is obviously a high PASI score is a risk factor for psoriatic arthritis. And such patients typically turn up in their 20s or 30s, primarily to dermatology. And if somebody had early psoriatic arthritis but had extensive psoriasis, they'd probably be referred to dermatology as well. So a very severe skin disease is a strong risk factor consistently for psoriatic arthritis. And of course, we in rheumatology, the people that we get referred with early PSA, we have to go looking very hard for psoriasis and re-diagnose apparent fungal nail disease or seborrhea, seborrheic keratitis or the likes, a scalp psoriasis. So for us rheumatologists, we often have to go looking for psoriasis, but in the big scheme of things, severe psoriasis, which typically turns up to dermatology, is a strong risk factor for psoriatic arthritis development. And hence
So with nails,
number
you
of
define nail disease as an important factor?
Yeah, well, yes, psoriasis first, but other things including family history, the presence of nail disease, possibly pitting more than other manifestations are definitely important. And then as people get closer to the clinical recognition of psoriatic arthritis, analogous to the situation in ACPA positivity, the presence of arthralgia is a risk factor also for the development of psoriatic arthritis. Of course, obesity also comes into the risk, and there's a linear relationship between the BMI severity, first published by Low et al. In Annals over a decade ago.
Why do you think that is, Dennis? Is that mechanical stress? Why
Yeah,
do you think
yeah.
obesity?
Yeah, very good point. So people typically say, oh, obesity is linked to adipokine release, and the omentum is an inflammatory type of fat compared to the fat elsewhere in the body. And truncal obesity, this central obesity, is linked to metabolic syndrome, etc., which is linked to psoriatic arthritis. So the sort of traditional school of thought is that it's the inflammation from adiposity. And of course, adiposity per se is linked to systemic elevations in CRP. But yeah, like you, Peter, I personally believe that adiposity is a risk factor for deep kebnerization or injury to enthesis. And the strongest evidence in support of that is the Elouet group TNF transgenic mouse that spontaneously gets enthesitis and colitis, but not psoriasis. But in that model, tail suspension, offloading gravity prevents arthritis development. So, yes, I personally believe there is a strong mechanical component at the enthesis. Yes.
In that nice table, you mentioned infections. Can you elaborate a little bit more? What infections drive psoriasis? Because we know that in kids, strep infection drives one kind of psoriasis, not the usual plaque,
Yeah,
guttate, I
gutted.
think it is, not the
Gutted.
plaque.
Mm.
Because I've always wondered about if you pick the highest risk patients, children with the same genes, would a strep vaccine be helpful?
Yeah, well, certainly the classic infection is, yeah, as you say, is a gutted psoriasis, which can be linked to psoriatic arthritis occasionally, but we tend not to see that in the adults that develop PSA. And of course, there are case reports of recurrent streptococcal sore throats and gutted psoriasis that can be cured by tonsillectomy. And the tonsil is a reservoir of T cells that circulate far and wide. And gutted psoriasis linked to HLA-CW6, which is obviously the classic gene linked to the severity of psoriasis. So yeah, there is something in that. So it's possibly similar to post-streptococcal reactive arthritis or rheumatic fever type scenarios where antibiotics might have some benefit. But yeah, there could be something in that. But the strongest evidence for infection was an epidemiological survey from Manchester, Ian Bruce and Alan Silman and colleagues in Manchester, where they looked at subjects with psoriasis and they compared them to controls who didn't develop psoriatic arthritis. And they saw that infections, including vaccinations, and one of the vaccines that they turned up was rubella vaccine, which obviously is given to girls in particular. But my own personal view, Peter, is that if you want to give a mouse arthritis, you give it the antigen you're interested in, plus an adjuvant, like lipid polysaccharide or fringe adjuvant. And a vaccine actually is rich in adjuvants. And we noticed, and others have noticed, that during the coronavirus pandemic, that SARS-CoV-2 infection was linked to flares in psoriatic arthritis. So my personal view is that the link with infection beyond the streptococcal story, where there's strong evidence for streptococcal M protein, I think, and cross-reactivity with various keratin-type antigens in the skin. Apart from that molecular mechanism linking adaptive immunity between the streptococcus and the skin, I think the psoriatic arthritis linked to infection and vaccines potentially is simply that people that are teetering along the brink when they have the non-specific adjuvant trigger, then that manifests potentially as a reactive arthritis in somebody with psoriasis, except the reactive arthritis doesn't get better after 3 to 6 months. It just carries on. And of course, we don't know why that is. And I think that brings us to the immunogenetic side of things.
Excellent. So we had a similar experience. We saw a number of people who had either stable PSA, got a vaccine and flared badly, or had nothing, got the vax and develop PSA quite within days almost. So
Yeah.
that's a nice trigger. Coming back to genetics, is there any genetic factors that are either protective or likely to drive the change from PSO to PSA?
Yeah, so this is an area of great interest. So of course, in the case of psoriasis, HLA-CW6 is linked to early onset psoriasis, psoriasis severity, extent, recurrence, and maybe response to therapy, the so-called type 1 psoriasis. But that particular gene isn't particularly linked to the arthritis. And then, of course, in psoriatic patients with axial inflammation, 30–40% of them are HLA-B27 positive. And Oliver Fitzgerald and Robert Winchester published that in subjects with psoriasis who are HLA-B27 positive, that the onset of psoriasis and the AS or psoriatic arthritis phenotype was within a year of each other. So to my mind, that points towards that adjuvanicity we just mentioned, triggering different T cell populations. One reacts in the skin and the other in the joint, particularly the axial skeleton, leading to disease. So I think that's a nice, fairly well worked out model, and it fits in with the uveitis, which is HLA-B27 linked as well, and Behçet's is HLA-B51. So these are these so-called MHC1opathies where class 1 antigen presentation to T cells drives different phenotypes. Now, the problem with the genetics in psoriatic arthritis beyond B27 and axial disease, several class 1 associations have been mooted, including B8, B37, B39. But the reality is, Peter, nobody is currently looking at subjects with psoriasis and arthralgia to immunophenotype them to say, like somebody with back pain, and if they're B27 positive, then more likely to, develop AS. We're not in that position with psoriatic arthritis, but I certainly believe there's class 1 immunogenetics, just as in B27 negative AS, other class 1 antigens come up like HLA-B40, which was shown there in Brisbane initially by Matt Brown and colleagues. So this is still a completely not well understood area. Is the role of the MHC class 1 genetics.
And
So yeah.
can you just put to bed if you're DR4 positive, are you more likely to get peripheral arthritis and psoriatic
Yeah, that's a good
arthritis?
one. DR4 has come up in several places, right? I
Hmm.
can't say I can put her to bed. It's certainly come up, and a class 2 association in rheumatoid tends to point towards follicular helper T cells, which interact with dendritic cells and drive B cells. So the DR4 shared epitope and citrullinated antibody titer has been higher. So the shared epitope being a risk factor for citrullination, which is then driving the rheumatoid. So the reported DR4 associations come up in psoriatic, but that could be T cells, CD4 helper T cells that are not helping humoral immunity, but are helping cell-mediated or CD8-mediated immunity. And again, I don't think that's well enough understood. But yeah, certainly class 2 associations crop up in many of these
And the other
diseases.
thing, the other thing Matt pointed towards is ERAP and IL-23R. Do you think they're relevant or only axial involvement?
Yeah, good point. So the ERAP SNP, which is the peptide trimmer for loading onto the class 1, so it's in the same pathway of peptide presentation on the class 1 to CD8 T cells. So ERAP1 strongly comes up in uveitis, ankylosing spondylitis, psoriasis, and Behçet's disease. But again, the point is we need to define the class 1 antigens better in psoriatic arthritis than to look to see if there's an epistatic interaction with ERAP1. And to the best of my knowledge, that hasn't been achieved yet. And I think, Peter, some of this comes down to when the GWAS revolution occurred, the ankylosing spondylitis phenotype is pretty clear. They've got X-ray sacroiliitis on their B27, most of them. Whereas the people getting into the psoriatic arthritis GWAS studies were never really properly phenotyped. are the axial or oligo or peripheral polyarthritis or dactylitis. So this has never been done properly, if you see what I mean. It just hasn't happened. And of course, in rheumatoid, we have small joint synovitis plus ACPA. And so it's relatively easy to get these homogeneous cohorts, but this hasn't happened in this transition to psoriatic arthritis. And of course, people may turn up with spine, which is sometimes linked to B27. They may turn up with a rheumatoid like polyarthritis, dactylitis, enthesitis, lower limb oligoarthritis. So this simple translational clinical phenotyping hasn't been done, which I think is one of the main reasons that the genetic studies in thousands of people haven't proven to be very as fruitful as in other settings.
So let's move on to biomarkers. I know Vinod Chandran's got a long list of biomarkers that he's been working on, as has many others. He tends to use them to differentiate from osteoarthritis, which seems very odd to me. But is there any gold in the biomarker area in PSO turning into PSA at this stage, or is it too early days?
So Peter, it's an area of intensive investigation, and of course, people with very severe psoriasis on its own, when you use these O-links or high fidelity cytokine measurements, you may see abnormalities in cytokine in the blood, but as you know, they're minuscule, like the elevations in IL-17 or IL-23 are low picogram range. There isn't a lot going on in psoriasis, but there's a little bit going on. So if there is severe psoriasis, it may affect the serum biomarkers, cytokines, and so on. And a lot has been invested in consortia like Hippocrates and the links doing extensive proteomics, and there have been previous studies, but nothing that's robustly thus far has been adopted. One caveat I'd point out, Peter, is if you develop a synovitis, you get adaptive synovial hyperplasia and infiltration of immune cells and joint diffusions. And if this is occurring in large joints, it tends to spill into the blood. But if you look at the early psoriatic phase, a lot of it is enthesial. And the enthesial structures are tightly linked collagen, so you don't get that swelling and fusion. But these structures are well innervated, so they're under pressure from low-grade inflammation, and there may be pain, but that doesn't lead to that spillover of biomarkers into the peripheral blood. So I think there's a real challenge here, taking the conventional, the conventional strategy for inflammatory disease because of the nature of enthesis, which naturally resists this puffed up joints and
Right. So
diffusions.
that's an important issue. So
Yeah.
looking at synovial fluid is unlikely to give you any better early biomarkers than
Well,
blood.
okay. Well, I think if you can glean synovial fluid clinically or an ultrasound, then you could argue that, well, okay, it's psoriatic arthritis already. So by the
Already.
time you can sample synovial fluid, you could argue it's PSA. I mean, in that vein, I should have said I was chair of the Euler Task Force on points to consider for psoriatic arthritis prevention. And half the panel that I was chairing said if somebody had joint pain with no visible swelling, but had ultrasound power Doppler, then that is psoriatic arthritis. They said, look, that's it. Get on and treat it. There's no need to do
Yeah,
research. Yeah.
fair enough.
Yeah.
What about another topic flavor of the month is the microbiome, Dennis? Is there anything in the microbiome that might help us pick the patient at highest risk or who's already transitioned?
Yeah, good point, Peter. So there's a particular issue here. Obviously, there's at least two microbiomes relevant to psoriatic arthritis. There's the skin one, and maybe the throat as well. We could talk about got it earlier, and also the intestinal microbiome. And of course, various studies in psoriasis and psoriatic arthritis suggest there's subclinical ileocolonoscopic inflammation. So the microbiome certainly could be important in that. And the answer is it's very early days and we don't know. But there was that excellent study from Denmark where they did fecal microbiota transplantation and psoriatic arthritis. And guess what? The, the FMT actually led to flares in psoriatic arthritis, indicating that changing the microbiota could trigger disease activity. So there's certainly a lot of mileage in that, Peter. But as you know yourself, the issue with the microbiome is there's so much metadata generated that there's always a statistical association that crops out, but it's very difficult to replicate. And the best example of that, you know better than me, is the melanoma data about microbiome predicting response to checkpoints, which was very exciting initially, but I don't think it can be replicated. So we have this issue with the non-hypothesis driven research, but data-driven research to try and fit a theory to the data that's hard to replicate. So I think this is going to be a difficult area to tease out.
And what about the use of biologics early in PSO to
Yes.
prevent PSA? Because Alexis Oggi says that it's all selection bias and stuff, and I wonder what. And because TNF can induce psoriasis, it makes the numbers difficult to prove statistical significance. What do you think about? And then mention targets 2317. What do you think about if they're aggressive with a biologic at a skin stage, you can prevent PSA?
Yeah, so in a nutshell, most of the drugs licensed to treat psoriasis have independent licenses to treat psoriatic arthritis. And we rheumatologists accept the earlier you treat, the better the outcome. So we have all of these drugs, including TNF blockers that treat psoriasis, not as well as the 23 blockers, but nevertheless treat psoriasis. I would take, my position is that most of the available data suggests that biological therapies, probably all of them, do have an impact on preventing PSA because you're treating it very earlier in the subclinical stages. And of course, it's buy one, get one free. When you treat people with a high PASI score, they merit therapy purely for the skin. And as a result, there's no, you're not investing any extra, economic resource or any additional toxicity or side effects. So yeah, there are those healthcare databases in the US suggesting that TNF blockers weren't linked to preventing PSA, but there's lots of biases there. But most of the studies, including these big data from Israel and the Italian data, most of these studies suggest that the biological classes reduce the rate of PSA. And also methotrexate, Peter, which is interesting because we say methotrexate isn't very effective for enthesitis. Yet, when given to psoriasis, the data from Argentina suggested that methotrexate reduced the rate of PSA evolution compared to topical therapy. Then the last issue is, are the IL-23 blockers superior? And there's a famous Sina paper from Lancet Rheumatology, and there will be a publication coming this year from my colleague Paolo Gissondi in Italy, who looked at over 600 patients where he carefully characterized everybody going on biologics, and he excluded PSA or arthralgia. And indeed, the IL-23 blockers in Paulo's hands as well seem to be a bit better than the TNF blockers at preventing arthritis. But how much of that, Peter's down to the excellent efficacy in the skin and drug retention as a possible mechanism needs to be teased out. But yeah, in a nutshell, there is some evidence saying that IL-23 blockers and maybe IL-17 blockers are slightly better at preventing arthritis development. I have to say, in our joint rheumatology, dermatology integrated service in Leeds, we rarely have ever see patients on a biologic for psoriasis or even a conventional DMARD such as methotrexate turn up with new onset bona fide clear-cut psoriatic arthritis. And I wonder if that's your experience as well.
Yeah, we certainly, I think a lot of collaboration now with derms and rooms in this particular area. And I think it doesn't eliminate the risk, but reduces it
Hmm.
significantly. And the other issue is in those difficult to treat patients, not the complex to manage, but the difficult to treat, where they have true ongoing inflammation and have failed a couple of our targeted therapies. We need the derm collaboration to be able to use combination treatment. Any thoughts on that combination treatment for the very, very difficult patient who seems to be secondary failure and cycling through targeted therapies,
Yeah.
but still with clear signs of inflammation?
Yeah, so I mean, there's two issues, Peter. There's the patient on a biologic like a TNF and for their skin, and it says losing effect. And you just wonder the TNF blockers when there's loss of effect, if there's neutralizing antibodies, and that's a lot less common with the 2317 blockers. But in our experience in Leeds, when people have, and it's not a common phenotype, but people may respond in their skin domain to an IL-23 or 17 blocker, but their joints are active. Then you switch them to a TNF blocker and you control the joints, and then the skin activates, and you have to use a combination. Historically, combination was a bit difficult because if you used ustekinumab and a TNF, you're blocking three cytokines, IL-12 and downstream gamma interferon and IL-23 and TNF, and we saw lots of infections. But it looks like with the 23 and 17 blockers, the safety is so much better. So if you have to use, particularly the 23 blockers, you can use combination therapy, and it's usually the 2317 to control the skin and typically a TNF blocker to control the joint. I'm only aware of one case ever where the patient needed the 2317 axis for the joint and the TNF for the skin. So and somebody told me about it. I've never seen it. So yeah, and obviously, yeah, we see lots of case reports in the literature as well of a TYK2 inhibitor or a TNF and various combinations, but it's not a common phenotype, Peter, right?
No, it's not that common, and I think it's our most difficult patients that we're talking about now. So,
Yeah.
but I must say, recent experience, a number of patients, the advantage of the 23 and 70, they're so safe that in combination, there's no infection penalty. But I've just seen adding a JAK, particularly a JAK1 preferred, in the situation when they're on a 17 or a 23 and you're struggling, excellent pain improvement, even without the synovitis improvement,
Mm,
similar to the rheumatoid
mm,
story. So I think there is that pain element and that crossover to the complex to manage where damage is driving pain and other things
yeah.
driving pain. So tell us a little bit about the screening tools, the topaz, the pest, and all those things. I don't think the derms find it there's a resistance to use. I don't know what it is. You could leave it in the waiting room and they could come in with a score and they could refer back to the GP and say, do something. But there seems to be resistance. I don't know what it is because they're quite nicely validated.
They're nicely validated, but the problem is in a busy service that you're talking about a third of patients with a positive screening questionnaire turn out to have an inflammatory arthritis. And in our various stretched services, the dermatologist maybe quite wisely realizes that if this patient has joint pain and they have bad psoriasis, then if I treat the psoriasis, I'll probably manage the inflammatory arthritis. And so there is an element of that. Yeah, so we use the PEST, which was developed in Leeds, and we also use the ARP questionnaire. And if the patient scores positive, they get seen by one of the rheumatology team. But we collect these patients for for research, right? We're particularly interested in arthralgia because Alan Zabotti from Italy and David Simon from Germany combined 400 patients with psoriasis, 300 of whom had arthralgia, and 20% of the arthralgia patients had clinical PSA, usually manifesting as small joint synovitis after 3 years. So that substantially enriches. So we think that's the group to target in intervention studies. Yeah.
It's interesting how Dern in our collaborative clinic has they're using the pest or the ERP, and they're sending a lot of people with nodal OA, painful nodal OA, who happen to have psoriasis.
Hmm.
And very reasonably, they ask the question, they've had the nodal OA forever, and now they're in a lot of pain. Is there PSA on top? And how you distinguish the
Yes.
PSA, whether it is or isn't, is very tricky, Dennis.
No, completely. And yeah, high resolution MRI, the DIP, and inflammatory osteoarthritis or active PSA can be virtually indistinguishable. It's quite hard to tell them apart. They're very similar disease localization with lots of ligament inflammation and extracapsular soft tissue inflammation, reflecting the epicenter is not RA like in the synovial cavity. So yeah, Peter, I've certainly seen people that are well diagnosed psoriatic arthritis, typically women in their 50s a decade ago, and now they're sitting in front of me saying, "Why doesn't my methotrexate work?" And they've got like
Mm.
ossified Heberton's and Bouchard's nodes and a clear OA phenotype, and you can't say to the
Yes.
patient, "You never had psoriatic arthritis," but I think what we think is inflammatory osteoarthritis plus psoriasis is a
Mm.
tricky one. And of course, there's some little bit of evidence for methotrexate maybe in hand away. So another maybe could be some genuine overlap because if you look at PSA, it tends to come on in women in their late 40s and they get it in their hands and neck as well. And those are common sites for OA. And it might be deep cavernarization. That's an OA type trigger. So I think it may be hard to disentangle these two because it's the same pathological battlefield.
Yes. It's very difficult. We try to use imaging and find areas of inflammation away from where you would expect OA to be. So just to finish, Dennis, in the paper you make a point about the definition of
Yeah.
pre-PSA. Do you think it's important to clearly define it? And if so, what would be your definition as a take-home message for pre-PSA? What should we look for?
Yeah, so first, if you take pre-RA in these ACPA positive patients, they have inflammatory arthralgia like stiffness for 30 minutes or so. But in the Zabotti paper in RMD Open last year, certainly people with psoriasis plus inflammatory arthralgia for 30 minutes or more, they have quite a short time, 3 to 4 months typically before they develop PSA. But what the data showed is people with non-specific MSK pain, like just aches and pains that didn't sound particularly inflammatory, were also at increased risk. So we're not really sure how to define the type of pain that's specifically linked to PSA onset, but certainly the arthralgia appears to be the key abnormality because it has a certain imminence of arthritis development. Whereas if you have nail disease, that's a risk factor, but it could take 20 years to translate.
Difficult. Just again to finish the Spanish with their whole body MRI could show enthesitis 3 times higher than the control. So, do you think that's a research future tool?
Yeah, the problem is when you do whole body MRI, normal subjects, like up to a third of them, have enthesial abnormalities, particularly in supraspinatus and gluteus medius or trochanteric bursal region. So it's still a research tool. And the other thing, in unselected psoriasis patients, let's say the rate of PSA evolution is around 1% a year. But if you do a cross-sectional study in psoriasis, 40 to 50% of subjects have this imaging enthesopathy. So there's a large subclinical iceberg of imaging enthesial abnormalities compared to the rate of progression. So I think arthralgia plus imaging changes is good. But as I said earlier, some people would say, well, don't fool yourself. That is PSA. It's just that you couldn't see it, but the imaging shows it.
And do you think we should be careful, patient on a TNF, looking good but complaining of a lot of fibromyalgia pain, actually have untreated enthesopathy?
Yeah, it's definitely. I think in such a case, if they have morning stiffness and a response to NSAIDs, and I know Euler and various people say don't give steroids, but if they responded to a methylprednisolone intramuscular injection, I think you could make an argument for a change of TNF or to another class, but that's not a common phenotype in my experience, Peter. But yes, it definitely occurs.
So thank you so much for your time, Dennis. We greatly appreciate it. If you'd like to know more about this review and others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you get detailed slide sets are available, imidforum.com. Please subscribe to this podcast on Spotify, iTunes, or other podcast media. Let us know what you think. We love to get some feedback. You can watch us on the Immune-Mediated Inflammatory Disease Forum on YouTube. And finally, you can follow us on Twitter and LinkedIn and Facebook to keep up with all the new data as it's published, and more coming soon in 2025. So, Dennis, thank you so much. Your
Thank you,
insights,
Peter.
as always, are greatly appreciated. Thank you.
Likewise, lovely to speak to you.